just make it very, very brief. So now, in the end, we talk about worst case scenarios of ICL. So far, all of us have been talking about the good of an ICL or a phakic IOL technique, but it does not mean that everything is rosy, cherry, and good. There are always problems. So let's hear of some problems which we can take care of. So the first and the foremost, very important thing that you should know is there is something called anterior subcapsular vacuolar changes. Now what does this mean? Now look at this. This patient was we seen on the first post-op day, and if a normal person would look at it, what will he say in the right image here? Visco deposit on the crystalline lens, right? Now, what if I tell you that there was no visco used in this case? Then what is it? So let's explore what it is. Here was another case. The same case. On the 30th day, the thing started resolving. See this slit lamp image? The same thing is resolving. On the 30th day, visco would have gone off within a few days. This is taking time. And when we took images, this was anterior subcapsular. So we looked up the literature after we had some 3 cases as such, and it was said that these are vacuolar changes, and the result is because of direct irrigation in the narrow space between the ICL and the crystalline lens. This is what I was talking to you about in this session in the beginning. And as a result, there is a development of transient, the word is transient vacuolar changes in the crystalline lens. And then it is observed that there is spontaneous reversal. Indicates that the surgeon should not rush to surgical interventions, but rather opt to choose follow-up over several weeks. So first thing is, like I just talked about, that if the lens is upside down, the first temptation is just flip it inside, and it can be done very easily. It just takes a second to flip it across. But this is the problem that would happen in the long run. You could have anterior subcapsular vacuolar changes. Now, as long as they are reversible, it may take a month to reverse, 2 months to reverse, not a problem. But here's the situation. Look at this amount of anterior subcapsular vacuolar changes. I said, fine, it will reverse. So we started following it up. And this was at 3 months. The haze is getting denser in the center. This was at 6 months. It was clearing up from the periphery and accumulating in the center. This is the ASOCT image. You can see all this area, cataractus changes in this area. And this is all that accumulation of that vacuolar changes. Now a pacified lens fibers, this is the cataract. And we had to do a cataract surgery because it was in the center, the visibility was down. So this case, we felt we have burned our fingers. It's very awkward to tell a patient just after 6 months that you're going to do a cataract surgery. But well, we could learn something from this and be careful when we deal with the patients in the future. So inference, do not irrigate between the ICL and the crystalline lens. That is the carry home message. Come what may, just irrigate over the ICL. But there's so much of visco under the ICL. And you're always tempted, yaar, isko bhi nikal do, nahi to ye sara ka sara secondary rise of pressure karega, glaucoma karega, nikal do. And that temptation, you have to resist. Somehow, just please don't go under the ICL. If you can take this message home, it will help you in the future. Second thing which we encounter now and then is a high vault. We know 2 things about a high vault. That the vault decreases with time in ICL, and if it is a very high vault, it can cause its associated problems, the angle closure from the side and rise of secondary pressure. So here is one patient size of ICL was 12.6, and look at the level of the vault. Both eyes. This is the right eye, vault 1400. This is the left eye, vault 1376. This was really high. Do we wait and watch for the vault to come down? No, we can't afford to. Anytime it will go into an angle closure. We have to do something fast. So it was decided we do an urgent explant. Replace it by one size lower. But now it takes time to get the same lens one size lower. So we monitored, and when it arrived, we decided that we are not going to take it out first and wait for 2 weeks and then do the other one. We said, let's monitor. If we land up into a raised IOP, we'll manage accordingly, but we'll do it in one setting. So this was a video of how we explanted this lens. And you see the difficulties we encountered in explanting this. So you had an ectropion of the uveal tissue because the iris was rubbing against the ICL. I'm trying to enter from the side. You can hardly go in. There's no space. See, entering from the other side. I'm almost rubbing on the uveal tissue, pushing the uveal tissue, trying to find a way in. But, well, I have found a way in. That was one. Trying to increase that space by visco. And then the main incision. Now the challenge was, how do I take it out? Because the standard teaching is, you prolapse the lens in the anterior chamber, put visco over and under and take it out. But here there was no scope of prolapsing that. So I had to hold it as it was in the posterior chamber. But once a grip was there, it came out easily. Then we replaced it with one size lower. Just one size lower, 0.5 millimeter. And see the difference in the vault. The vault has come down to right eye 710, left eye 212. It's come to a lower vault than normal now. See the dramatic change? So this dramatic change will happen in smaller eyes. In bigger eyes, you may not find such a dramatic change. Okay, one last one is a lens upside down. I'll just take a minute. So this patient was operated somewhere, lens was placed upside down. The surgeon did not realize that. So when it is upside down, the haptics are facing upwards and they are pushing the iris against the cornea. Total peripheral anterior synecdoche. And the lens is rubbing on the crystalline lens continuously. And the patient was given anti-glaucoma medication for 4 years by the doctor. And it just turned up. I saw that was my first case. And I said, okay, this is upside down, let's take it out. So I took out the lens, tried to break those peripheral synecdoche. And the question was, should I put in another lens or not? So this was a lens without the central hole. So we got another lens with the central hole. We placed it back. But what is noticeable is that even after 4 years and the glaucoma, there was no cataract. Unbelievable. They say, how can it be possible? 4 years, you have an ICL rubbing on the crystalline lens, pressing on it. With glaucoma, even glaucoma 4 years, you would have a cataract. And this patient, fortunately, was lucky, didn't have a cataract. Thank you so much.